what is the Age-Friendly Healthcare Systems Initiative?
Can you tell us what specifically drew you to emergency medicine?
So the age-friendly health system really focuses on that, but basically it's stuff that we're already doing. Having these different programs has really, we can see what we're already doing here and identify where we might be lacking in something.
Welcome to the Empowered Elder Podcast.
When people think about emergency rooms, they often picture fast decisions, critical care, and life-saving interventions. But what many people don't realize is that older adults now make up a growing portion of emergency department visits. According to the Centers for Disease Control and Prevention, adults age 65 and older account for more than 20 million emergency department visits each year in the United States. And that number continues to rise as our population ages.
And yet many emergency departments were never designed with older adults in mind. Bright lights, long wait times, and those unfamiliar environments and limited access to supportive services can make emergency care especially difficult for aging patients, particularly those who may already be navigating complex medical needs or challenges at home.
But across the country, there's a growing effort to rethink how emergency care is delivered for older adults. Health systems are beginning to redesign care through age-friendly initiatives, geriatric emergency department standards, and innovative programs that better support both patients and their families.
Today's guest is helping lead that transformation. Dr. Holly Buschhorn is the chief of the emergency department at the Western Colorado Healthcare System within the VA, where she is advancing programs that support older veterans through age-friendly care models, geriatric emergency department accreditation, and initiatives like GeriVet.
Her work reflects a powerful idea that improving systems of care for older adults doesn't just improve health outcomes. It restores dignity, supports families, and ensures that people who served our country receive the thoughtful care they deserve.
We're your hosts, Nicole Rabalato and Tasha Beckman, and this is the Empowered Elder Podcast, where we talk about home, heart, and the next chapter of life.
Let's get started. Thank you so much for joining us, Dr. Bashorn. We really appreciate your time.
Yeah, well, it's good to be here. Thank you.
Can you tell us a little bit about your background and what first inspired you to pursue medicine?
Sure. So I didn't take quite the traditional pathway. I took a few years off between undergrad and medical school because I really wanted to make sure that what I was doing was what I truly wanted and not just going through a process. And I knew I wanted to spend the rest of my life making a difference. And I decided in medicine, I really can do that. I always had an interest in biology, and then I also had an interest in just people in general. And being able to combine those two, I realized I could do in medicine. And like a lot of people, I think in medicine, they also, I had a personal family experience in the healthcare setting that really influenced my decision to go into medicine.
That's fantastic. And emergency medicine is a very unique field. So can you tell us what specifically drew you to emergency medicine and what did you love the most about that in your early career?
For sure. Yeah. With emergency medicine, I feel like that's an area in medicine where you really have an opportunity to positively impact somebody or their family in a very really high stress, intense situation. So I really feel like that's a really meaningful time in somebody's life, and sometimes not a very good time, right? And to be there and to be able to help people through that, both personally and professionally, that's something that was really interesting to me in emergency medicine. And I also really, when I was looking through specialties, once I was in med school, because I didn't go into medicine knowing I was going to be an emergency physician, but as I was going through clerkships, I realized that I liked all of them. And I couldn't really decide what I wanted to do yet. I wanted to have training that specialized skill sets. And with emergency medicine, you do have experts in the acute care of, acute illness and disease. And so, but that also expands throughout every every different specialty in medicine. So I really like the overlap with that.
What then caused you to transition to full-time work with the VA?
I took a part-time position here at the VA quite a few years ago when I was still working full-time in a tertiary care center here in Grand Junction. And so I started that part-time just to add a little bit of diversity in what I was doing with my work. And they also needed help with coverage. So, quite a few of us did that. Then over time, I liked being at the VA more and more. And then the opportunity for the chief position came up, and I applied for that position and then transitioned over as chief here at the VA and resigned at my other position in the community.
Got it.
And you have a very special interest in geriatric care, and that seemed to have started a little bit, earlier in your career, and it's continued to evolve throughout your career. How did that early exposure grow into the work that you're doing today regarding the geriatric care?
Right, and it actually coalesced all very well, and I was very fortunate for that. But even when I was in med school, I knew I had an interest in geriatrics, and in fact, they had a longitudinal program that I took part in over the 4 years of med school, and they combined us with independent older adults, and we basically would just like hang out with them or do things with them, or over time sometimes I would be in medical visits with them, and it was really a way for, I think, medical students to see, a lot of our interaction with older adults in medical school is those seeking care. This longitudinal program was a way to see how people are living and aging, like in a healthful way, and potentially breaking any preconceived notions about what it means to be an older adult. It was a great program, and my husband and I actually became really close with the couple that we got paired with, so much so that over the years, like after med school, we continued to keep in touch with them and would see them until they both have since passed away. It was actually a really great experience, and they were so funny, but they would do things, but they also taught me a lot. They really showed me how you can age well and age in place. I mean, they lived independently pretty much until their passing. And, they really surrounded themselves with a lot of younger people and kept busy with a lot of social activities. And, they would do funny things like they painted their car yellow because they wanted, they knew that they probably weren't as safe a drivers, but they still wanted that independence. So they figured if they painted their car yellow, that people could at least see them. And they just had like funny ideas. And, for my husband and I, who are in our 20s, we're like, this is crazy, but now that I'm at this point in my life, I'm like, maybe I should paint my mom's car yellow.
Yeah, maybe they were really ahead of their time with that thought.
I had an interest in order to even become involved in that program. And that just was more interesting, or it, kind of fostered that interest. But I ended up not pursuing, I once considered going in or doing a fellowship in geriatric emergency medicine, but I never did that, though I continued an interest throughout my career. So, I don't have any specific specialty training at a fellowship level in geriatrics, but it's always been an interest. But I feel like I got lucky when I was talking about everything kind of came together well. There was already a developing program here at the VA when I started. And so when I started, I was able to take over what had already, was in process and expand upon that. So it was, I felt really lucky that this program was already at the VA.
So traditionally, what challenges, from your viewpoint, do older adults and older veterans experience in traditional emergent care?
Well, I think in emergency medicine in general, and I think it's come to light a lot more recently and publicly that, EDs are consistently constrained for resources, yet EDs are really the safety net for our strained healthcare system. Everybody right now is struggling for resources, and it's often, I feel like, difficult for even any aged adult to understand kind of the process. I feel like older adults have more potential comorbidities or more needs, even things like being hard of hearing or mobility issues. Those things can help or can create barriers and difficulties with care. And I think in emergency medicine, a lot of times when somebody comes in, we really just focus on that chief complaint or what could be going on, or, what's the acute issue that brought the patient or veteran in for care. With older adults, I think there can be multiple layers, multiple issues going on. And it's somewhat, it can be challenging in an emergency room setting to kind of peel those layers apart to figure out exactly what's going on and how best to help an individual. And, there's a lot of, I think, challenges in caring for older adults and in the emergency department. And I think actually, as we go through the program that we have here today, as well as some of the national initiatives and actually international initiatives that are going on, I think that we might be able to better tease out as we discuss, the different programs and aspects of those.
So there's an international scope as well. Like we're aware of the multi-sector plan on aging 36 state initiative, but there's an international initiative as well.
Well, it's interesting. So we were recently designated the silver designation for the Geriatric emergency department accreditation through the American College of Emergency Physicians. And that is actually an international program. If you go on the website, they're actually listed international sites that are accredited with the different designations that they've laid out. Yeah, so in addition to national, and there's also national initiatives in addition to what I just described, the JEDA classifications for which we have attained silver designation. But there's also a different program that we're a part of, which I think you had alluded to, but the age-friendly health systems. I don't know how much you guys know about it, but I'm happy to talk more. And I think it's really important because that's one of the things that we're working with too, to make sure we're providing the best care we can for our older veterans.
We would love to hear more about that.
And I would like, you had talked about the silver level designation and having that accreditation. Can you, before we go into the other pieces we want to talk about, can you just tell us what does that accreditation mean for patients and families? Like, how does that help, and what's the difference in having that accreditation?
Right. And that's, that's a great point. And that is really something I wanted to focus on today. There's different levels of care that's provided, or, settings that are involved, or ancillary services that can be brought in. And as you go from bronze to gold, it increases that level. So, since we're talking about the geriatric emergency, or it's Geriatric Emergency Department accreditation. That's through the American College of Emergency Physicians. And basically what they've outlined, it's a framework to establish geriatric emergency care. This is essentially the same spin, but it's either actually a physical setting, or more commonly it's a set of best practices that are really used in emergency departments. And so it's not physically a different area, but it's making sure that there's physical environments that are accessible or more amenable to older adults. It gives guidelines for having certain interdisciplinary staff like social work, physical therapy. It gives kind of guidelines on accessing supplies like mobility aids, such as like canes or walkers, those sorts of things. And then also it really ties in importantly with transition of care. So, with an emergency department, that's just one snippet in somebody's healthcare experience. And oftentimes you require follow-up from an emergency department visit, whether it's being admitted to the hospital or whether it's outpatient. And so it's really focuses in on that and making sure that there's processes in place to establish follow-up. And so that's with that accreditation program, it gives basically guidelines for which you can then fulfill and apply for specific designations.
Do you think as our population continues to age, there will be a trend towards building separation for that geriatric care service, similar to the pediatric care emergency departments?
I do. I think everybody is acknowledging that there's going to be an increased need for care across the board in medicine for older adults as we look at our aging population. And so if you look, there's more and more literature out about, especially with emergency department care, and how we're going to best deal with that in the future, and how we can, utilize the limited resources that are available to best serve older adults. So I do think it's going to increase in familiarity, and also just the experience itself will improve as we kind of acknowledge that there are unique needs to older adult, or to caring for older adults.
Sure.
That's fantastic.
And coupled with that, what is the Age-Friendly Healthcare Systems Initiative?
Yeah, so that is a separate program. So it's an initiative that was started by the John Hartford Foundation, as well as the Institute for Healthcare Improvement. I think there's a couple of other associations that are in support of that. But it basically is an initiative that really focuses on what matters most in caring for an older adult. The age-friendly health system really focuses on that, and within that initiative, you can also achieve certain designations. And we're currently a participant in the systems, but we are actively pursuing like the next level. But but basically, it's stuff that we're already doing. But having these different programs has really been good because we can see what we're already doing here and look at at different initiatives and identify where we might be lacking in something so that we could augment the process that we have locally. It really is just more focusing on movement. And we do actually, when we're doing our assessment or an intake, we talk about actually people hitting the ground. But really that's just the ultimate result. What we want to do is identify people who might be at risk of that and prevent it from happening in the first place. The more falls you have, the higher chance you have of injury, and with injury comes it can be a spiral of development of additional problems. And so if we can prevent from the get-go, you can help preserve independence and function a lot longer.
I was thinking back to like when individuals come into the ER and, with the initiative, the Age-Friendly Healthcare Systems Initiative, and your ER department has that extra thought process and processes in place to help individuals who are coming in. Do you find that it also helps? Because a lot of times there may be individuals that come into the ER that may not have an advocate for them or somebody that can help speak on their behalf. Do you find that these initiatives help you in that process to framework, how you're going to care best for that individual if they don't have an advocate?
Yeah, I think so. And I think that is important. And that's one of the things that, and I can explain further what we do, which has already encompassed, that problem with the intake to the ER in itself. But that's, part of the initiatives we were talking about having an environment. It's, the ACEP, which is the American Academy of Emergency Physicians, ACEP, they're the ones that have the gold, silver, bronze designations. They identify that can be challenging, especially if you have somebody that can't communicate well their goals and needs, to really make sure that there's an environment of, one of the things that we have to do is say, yes, we have 2 chairs in rooms so that patients, advocates or family can be in there with them. So I think that is important. And I'll touch base more on that when we actually talk about the program that we have here and how that's addressed.
And is the program that you're referring to the GeriVet?
Yes, exactly.
Okay, so let's jump into that a little bit. So what is it? What started it? And where do we go from here?
That's a great, yeah. And this is really what I'm really passionate about, and actually proud of, with what we do here at the VA. And I feel like just getting the designations and, participating in the initiatives that we were just discussing was more just, augmenting what we were already doing, and getting more recognition for what's already being done here. But here locally at our VA, so we're on the Western Slope in Grand Junction. And the most common age of veterans that we care for is, or the demographic is age 65 or older. So it really behooves us to make sure we're doing geriatric care well, because that's the majority of our population of the veterans that we serve in our ER. And so, we talked about really in the ER, you kind of focus on one problem, but by establishing a program like the GeriVet program, we're able to really focus more holistically on the patient, and identify needs or really vulnerabilities that an older adult might have, to make sure we're addressing, maybe underlying issues and not just the acute problem. And this is, I think, goes back to what you were talking about. People oftentimes can get overlooked because they're not asking or even knowing to ask for help. And so by establishing a process to identify certain vulnerabilities, it helps a patient themselves advocate for their needs. But also, if there is a caregiver present, this is the opportunity for them to to step up and voice concerns as well. And so this GeriVet program that we have here was actually adapted from a pilot initiative program at the Cleveland VA years ago. So I think the VA, it's an excellent healthcare system, I think, for innovation, because I mean, it's immense and it's associated with multiple academic affiliations. There's always process improvement projects going on and research going on. And it's great to have such an institution at a national level, because when other facilities do something and identify something that can be done well, then they can share it to other facilities. The Cleveland VA had started their own GeriVet program. And so we were able to use what they did and basically adapt it to our smaller ER. So GeriVet stands for Geriatric Emergency Room Interventions for Veterans. And we actually, a little bit of an aside, but we recently just had our Joint Commission survey a few weeks ago, and our facility was described as small but mighty. And I really think that's true, because what we've done is taken this, a large academic institution and a huge VA that's offering this service, and we've kind of pared it down to our small facility and have been able to make it work and actually really work well with the resources that we have here. What we did is use the framework of the other VA's GeriVet and created what we needed to do here to make care kind of tailored to our veterans. And so the way the process works is anytime anybody goes to an emergency department, you check in at triage. And during the triage process, anybody age 65 or older for us gets screened with what's called an ISAR. It's a tool that identifies seniors at risk. And the questions for that, and this is again asked of every single person that checks in age 65 or older, is, do you need assistance on a regular basis? Have you recently been needing more help? Have you had recent hospitalizations? Do you feel like you're having trouble with your memory or your vision? Or how many medications you're on? And if they're over 3, that could be concerning. And so if people have answered yes to 2 or more of those questions, then that triggers the full geriatric evaluation, which is the GeriVet consult. And so from triage, we identify veterans who might be at need, and from that, they get the full assessment. And with the assessment, we have our intermediate care technicians, which are serve as our ER techs. It's a program that we have in the VA, but they're veterans themselves. And so it's great because there's that instant connection of shared commonality of being a veteran themselves, and they're now being able to literally sit down with these veterans and taking really making time for them to figure out what more they might need. And so they will go through the more comprehensive evaluation, which includes a falls assessment. We do delirium and dementia screens. We assess their functional assessment, like checking for ADLs or activities of daily livings, like do they need help with bathing or cleaning or eating, that sort of thing. We ask actually about caregiver burden. So we really do try to bring in the family members as well, because a lot of times caregivers struggle a lot, and to be able to provide them resources are huge. We also actually do screenings for elder abuse just to make sure that that's not a concern, and would address that if needed. And we also look at medications with pharmacies. So if we as we go through this process, if we identify that there's any areas of concern, we address those and link them up with resources or needs that will help address that. So for instance, if there's a concern for frequent falls, we talked about that a little bit ago, but if somebody is stumbling or falling frequently, we can address that further by having them, we can place a consult for physical therapy. We can actually even have physical therapy during certain times of the day, come assess the patient if we feel that's needed. The VA has a GeriVet program that we can refer them to, so they can basically exercise and balance or work with their balance. If we identify that there's a need for a cane or a walker, we can give that to them at the time. With other issues, if there's concerns that somebody might need like skilled or unskilled help at home, we can incorporate social work, and either through the ER social work or folks that are supporting us in the ER, or through their primary teams, to get a home health and safety assessment to see really what their needs are. And so it really has, we can even give, if we identify that there's a need for a shower chair, we can get that for them. It's things like that. that really, I think, address a lot more than just coming in for, whatever, chief complaint they had to see in the ER. It's really a more comprehensive way to assess the needs of older adults. And, for instance, there was one veteran that came in recently that had a medical issue, but in performing the GeriVet screen, it was identified that his wife had recently passed away, and the wife was really the caregiver for this veteran and providing most of the support. And without the wife, the veteran just wasn't doing well, and by identifying that, we were then able to hook him up with a lot of resources that were really able to support him and enable him to live independently longer. And that also with this program, we can set up all these these different support systems as we need, or follow-ups or additional care. But then we also do follow-up calls. So the techs that I was referring to that are the ones that do the screening by and large. Sometimes nurses will as well. But they'll make phone calls to these veterans a week after to make sure that all the needs they reported as maybe having were getting addressed, and if needed, we'll also follow up with them at 30 days. And so I think one of the things that makes us unique about being in the VA system is we really have a lot of resources, and it's a closed system. So it's a lot easier, I think, for us to give continuity of care from the ER because, literally down the hallway is their primary care team, and we can access their primary care team. We can access all of their records. So we know what's already going on with them. So it's really, I think it's really helpful when you're taking care of patients in emergency departments to be able to obtain additional history. And it also helps on the flip side too of the visit with follow-up. In our VA, we do, if we identify that somebody needs to be admitted, we do have an inpatient service that we can admit to. If we feel like they're, safe for being discharged home, we still have a number of resources like I, described already that we can offer to make sure that veterans get the follow-up that they need.
Today's conversation highlights something many families don't realize until they experience it firsthand. Emergency departments were never originally designed with older adults in mind. And yet, as our population ages, more and more families are navigating these moments with aging parents, spouses, and loved ones.
What Dr. Bashorn has helped us understand today is that these challenges aren't just individual experiences. They're often system-level issues. And when healthcare systems begin to recognize the unique needs of older adults, it opens the door to better solutions for patients, families, and providers alike.
In the next part of our conversation, we'll explore how those solutions are already taking shape, including the Age-Friendly Health Systems Initiative, the 4Ms framework, and the innovative programs the VA is implementing to better support older veterans and their families.
So be sure to join us for part 2 of our conversation with Dr. Holly Bashorn, where we'll dive deeper into how emergency care is evolving to better serve older adults.
We're your hosts, Tasha Beckman and Nicole Rabalato, and this is the Empowered Elder Podcast, where we talk about home, heart, and the next chapter of life.